Okay, we are going to try and take two here. Gonna see if I got confirmation that my slides are showing up this time. Um, well, welcome to our first virtual Proflex workshop. Thanks for joining us. Um, if you didn't join on before, I'll introduce myself just briefly. My name is JD Shepard. I'm a board certified orthopedic specialist in physical therapy. And I'm also the clinic manager at the Proflex location in Gaithersburg. We have 9 locations located throughout the DMV. So feel free to check out our Facebook page or our website for the other locations. Also want to thank Fleet Feet for helping to promote tonight. A little bit about my background. I am a runner myself. I ran track and cross country in college at a small D1 school in Ohio. I've also been treating runners ever since I started as a physical therapist back in 2012. I also specialize in treating athletes with foot and ankle conditions, as we see a lot of that with runners, but really the whole lower extremity. So we'll go ahead and jump right into it here, talking about running and injury. So we know that up to 80% of runners will come down with an injury at some point during the year. And about half of these injuries tend to involve the knee. And when we look at these injuries and why it is that people get injured, it's really multifactorial. So we look at dosage being more important than biomechanics being more important than structure. So what does that mean? It means that what you're doing or how much you're doing is more important than how you're doing it, how you're running form, which is more important than your body structure or how you're made. And that is actually pretty good news, because the thing that we have the most control over tends to be the thing that causes or has the biggest impact in running injuries. When we talk about running form, that can play a role, but it's also really hard to change your running form. It can be done, but it's not as easy as a lot of people make it out to be. And often in the long term, people tend to just go back to how they were running in the past or how they always were doing it. It can be a good short-term tool, though, to take some stress off of some areas. So all these things combine to lead to an injury. And this graph here just kind of puts it into a visual. So you have on the left side a person's capacity or what it is they're able to do. And on the right side of the screen, the load that it is applied to that individual or that tissue structure. And when that applied load goes above the capacity, that's when we see injuries occur. So as we're talking about training with pain, we first have to understand what exactly is pain. We could spend a whole hour or more talking about the science behind pain, but we'll just try and sum things up here just a little bit. So what is pain? The Marine Corps would say that pain is weakness leaving the body, but we're going to look for a little bit more of a scientific definition. And so here are 2 definitions that have been put out. Just kind of highlighting the big parts is that, it's associated, if you look at the first definition, with actual or potential tissue damage. And I really like the second definition, which is that it's a multi-system output activated by the brain based on a perceived threat. So it doesn't have to be an actual threat, doesn't have to be actual tissue damage going on, but it's our body's perceiving that there is a threat there. So what does that mean? It means that tissue damage isn't necessary or sufficient to create pain. And it also means that there's lots of things that can affect our pain. Things like fear, anxiety, stress. I think we're all just kind of walking around with a little more stress or anxiety these days. And all of that can play a role in pain. Another thing to point out is sleep. So how much sleep you're getting at night. We know if you're getting 8 hours of sleep compared to 5 hours of sleep, if you're only getting 5 hours of sleep, you tend to experience more pain. Everything else kept the same. So when I talk with patients about this, I really like to use metaphors and examples just to drive it home. So the first one being, think about pain as an alarm system. And it's letting us know, an alarm system, of that potential threat. And if we take that example a little bit further, you can think of, maybe you've been in a big office building in the past, or a dorm, and the fire alarm goes off, and you have to evacuate the whole building. Walk down 14 flights of stairs. There's 3 huge fire trucks out front, firefighters running in, and then firefighters clear the way, and they say, you know what, it turns out it was just Karen burnt some popcorn in the microwave. There was no real threat to the building ever burning down. And we see that a lot with pain, especially in individuals with chronic pain, where that alarm system tends to get out of whack, where that a little bit of discomfort, a minor issue, causes a lot of pain. Another example we'll use is the example of an overflowing cup. So we talked about pain already being really multifactorial. And if we go back to our other slide, we have all these things that can contribute to pain, along with that tissue damage or potential tissue, the actual tissue damage. And when that fills up and the cup overflows, that's when the person will experience pain. And you can decrease any of these things and potentially have an effect on pain. And we know that every time, every injury, every individual, how much these factors are a role is different. Sometimes stress and anxiety might play a really big role. Other times, not at all. Sometimes the tissue damage might be the driving factor. Other times, it may not. And then the last example that I love to use, and it's an actual study that was done, and it looked at patients with neck pain. And what they did with these patients is they took virtual reality goggles and they put it on the patient, and then they had them turn their head, and then they would measure when that patient reports that they feel pain. So under the first condition, it was exactly normal, exactly what you would normally see. They turn their head and they say, "Ooh, I have pain when I turn my head," and they measure it, and it's like, okay, that's 50 degrees where you said you had pain. Then they make it look, with the virtual reality goggles, like they're turning their head further than they actually are. So they turn their head, they say, "Ooh, that's where it hurts." And turns out it's where it looks like they're at 50 degrees when they've actually only gone 40 degrees. So that's telling us that the tissue isn't really what's involved. There's other inputs. Our senses play a role. The really cool thing, I think, is when they do the opposite. They then make it look like you aren't turning your head as far as you actually are. Again, they turn their head. They say, "Oh, that's where it hurts." They measure it. Turns out, oh, that's 50 degrees, or 50 degrees where it looks like you're at. However, they've actually turned their head 60 degrees. So this time they've been able to go further, and those tissues have been under more stress without any pain. So oftentimes the question that I get and patients wonder is like, well, is this pain even real? And to that, we have to go to the great philosopher that is Albus Dumbledore, when Harry asks, is this real, or has it just been happening inside my head? And Dumbledore replies, of course it's happening inside your head, Harry, but why should that mean that it's not real? So all pain is coming from the brain or your head, and all pain is real. Anybody that tells you you're just making it up, they don't understand what pain is. All pain is real. So now that we have an understanding of what pain is, we need to know, okay, when are some times where it might be a little bit more serious, times where you would want to go seek some medical opinion. So here, things like severe pain. So we think about pain being an alarm system. You tend to have a buffer. You might have a little bit of pain before there's any tissue damage. But if you're having severe pain, that's a good sign that there might be something going on. Any type of swelling, another one where your leg tends to give way or buckle, or if that joint locks up, be a good idea to get it checked out. A real big one is bone tenderness, especially in your shin or the outside of the foot. Would be worried about a stress fracture. So you definitely do not and should not be running through a stress fracture. And then finally, any numbness or tingling. So say those things aren't going on, training with pain, what type of pain is okay? So a couple questions to ask yourself. First, is it changeable? Can you do something to modify the pain, whether you run slower? Sometimes running faster can decrease the pain. Is the surface you're running on change it? Or can you shorten your stride to decrease that pain to allow you to run? The second is does it change your form? So if your form's really starting to change because of the pain, that's a time where we say, okay, let's back off. Probably should not be running through that. Then is it tolerable? If it's tolerable, not changing your form, okay, that's generally okay, as long as that pain goes away within the next 24 to 48 hours. So if that pain is lasting for 3 days, that's a sign that you're doing too much. You need to back off. Ultimately, though, it is your decision. As long as you're ruling out a serious pathology. Some general guidelines on this slide here: 0 to 2 pain, we tend to think that's pretty safe. 2 to 5 tends to be acceptable, but once you get up to 5 out of 10 or higher, that's much more high risk. This specifically is talking about tendon pain, and so each structure can be a little bit different, but again, anytime you're having that severe pain, you're probably going to want to back off. So now talking just about a few conditions that we see a lot with runners. First one, any type of tendon issue, tendonitis, tendinopathy. Some things of note with tendons is the pain tends to come on later. So oftentimes it won't be necessarily while you're running, but could be the next day. When we also look at the research, it looks like the activity that you're doing that causes the issue can also be delayed anywhere from 4 to 14 days. So it could be that you increased your training a week ago, you don't have any of the symptoms for a week, and then you all of a sudden wake up and you have some pain, and people have a hard time making that correlation of, well, I didn't really change anything over the last 3 or 4 days. It could be something that you did 1 or 2 weeks ago, and you just didn't have any symptoms, which sounds like something else that we're dealing with these days, where you're not having symptoms for 4 to 14 days, but could be asymptomatically spreading coronavirus. The things with when to train with this type of pain, with a tendon issue, chronic tendon issues tend to do better with training. So anytime that pain's been around longer than 2 months. However, if it's an acute type of pain or really irritable, those don't do well with running through. It's better off to take a few days to a week off to see if that just calms down. Also of note, it's really rare to rupture a painful Achilles tendon. Most of the time when a tendon ruptures, we think about a 30 or 40-year-old male playing pickup basketball, has no pain at all, steps back, and their tendon ruptures. We think that pain is actually protective, not allowing you to rupture that tendon or do an activity that would rupture it. Then we'll talk about runner's knee. So a little advice on this. What exactly is runner's knee? It's also known as patellofemoral pain syndrome. We talked about before how 50% of running injuries involve the knee, and then of those knee injuries, patellofemoral pain syndrome is by far the most common, where it gets its name, runner's knee. So it's essentially just that the knee is more sensitive to load and more sensitive to pressures. The tissue in the knee can't withstand the load that it could previously. So you'll often have pain with going downstairs or squatting because those things tend to put more load onto the knee. Also, as mentioned before, anxiety and depression is highly correlated to patellofemoral pain syndrome. So we tend to see it more in individuals that might have some clinical depression. How to treat it? At first, just try and calm down the knee however you want. Put ice, heat, tape, any of those knee sleeves. Those can all decrease pain. It might just be, and likely is, just placebo, but if it's able to calm the pain down and allows you to run, that's fine. I often think of it as just trying to give the knee a hug. And if we think as pain being a potential threat, you feel a lot less threatened if you've gotten a hug. So the threat isn't as high. And then once you do that, just gradually increase your activity. Don't make big changes. It's also a good idea to add in any type of knee or hip strengthening, which has been shown to be protective and decrease pain in the literature. So what does that look like when we say increase your pain or increase your activity gradually? So if we go back to our example here, where we had our person who went above their capacity, what happens then is your capacity decreases. And so things that you were able to do before, like going downstairs or squatting, are now painful because you don't have as much capacity. What often happens, and what people do, is what happens in this slide is if you look at the applied load there, it's much lower than the person's capacity. And our bodies adapt to the stresses that we put on them. So if you are underloading that tissue, your capacity can actually decrease. So we don't want to do that. So how do we gradually increase? And what we see a lot is, one, people will decrease their activity quite a bit, and then they'll try to go right back to what they did before, and their capacity has decreased even further. So rather than do that, what we want to do is just go just above what it is you're able to do. You might feel a little bit of pain, a little bit of discomfort. That's generally okay because we talked about it's not necessarily tissue damage. If all those things that we talked about before are intact, your form's not changed, pain goes down within 24 to 48 hours, and it's tolerable, body adapts to the pressures we put on it, and your capacity increases. And then you do that again, all the way back up to being able to do whatever it is that's required of you. Now, do you stop here is the question. My answer is no. You don't want to stop here because here you're playing with a fine line. If you stop here, as we talked about before, pain being very multifactorial, what if you don't get as much sleep one night? Or you're going through a period of time with more stress and anxiety, you do the same run, but your capacity is decreased and you end up with an injury. So you want a little buffer. So you do a little bit more so that your capacity is above what it is that's required of you. Now, this sounds easy. Sometimes it is, but sometimes it isn't. And believe me, I know it's not as easy as it looks. That's why I have a job. So the other question is, where does cross-training fall into all of this? Cross-training allows you to maintain that fitness and avoids complete rest if you aren't able to run. Things that I tend to tell people is try and mimic that cross-training to what your actual training program was going to look like. So if you were going to do a workout where you ran 3 minutes hard and then rest for a minute, run 3 minutes hard, rest a minute, you should be doing that same thing on the bike. Oftentimes people will just kind of be like, oh, I'm cross training. I'm just going to go on the bike for a few miles, and their fitness decreases. It's better than doing nothing. But if you can mimic what your training is like, when you are able to run, you'll be able to more quickly get back to where you want to be. And hopefully on that, whenever we get back to racing, race day will look a lot better. Just to sum things up though, if in doubt, check it out. So with all of that said, if you're not sure about something, get it checked out. We're living in different times now where it might not be as easy to get it checked out. But telehealth is something that's here, and physical therapists haven't often been thought of as providing telehealth, but we are now. Luckily, a lot of insurance providers are now allowing physical therapists to provide telehealth and reimburse for it. But at Proflex, we're if you want to do a telehealth visit, even if your insurance company's not covering it, at this time, we feel like it's appropriate to provide that as an option to all of our patients. And it's also been shown to be in many studies, or in some studies, hasn't been studied a lot, that it's just as effective as coming into the clinic. And then here are just a few helpful resources that you can check out on your own. I highly recommend runningphysio.com. A physio over in England who works with runners has lots of great information on his website about a number of different conditions and training. And also Lorimer Mosley's, if you like TED Talks, his TED Talk on why things hurt, Google that. It's a very entertaining talk that goes into more depth on pain. But thank you all for joining this week in our first installment. Thanks for bearing with me on some of the technical issues that we had originally. We will be doing this each week, so hopefully you can join us next week. We're gonna have a workshop on ergonomics and setting up your workstation at home. And if you have any questions or feel like you need to see a physical therapist, feel free to message us on Facebook or give us a call at 301-990-9599. Thanks and have a great day.